All right, so we're going to do our injuries first.
Okay.
And I want to start with the history part, because a lot of times we get clues that we're working with an injury because of the history. Almost always when a patient has a lesion that is related to a physical traumatic injury or a chemical injury, it is something that has just happened recently, had a rapid onset kind of a thing. It's not been an ongoing process. There are exceptions to that rule, but most of the time it's recent onset, and often whatever injury initiated it produced changes that were very painful at the beginning, and then as the body starts healing the injury, the pain subsides, and usually oral injuries do completely heal within 2 weeks, depending on the extent. Sometimes just a few days, 2 or 3 days, depending on the size of the injury. The problem that we have is that sometimes we have patients with repeated or chronic injury. They're continuing to re-injure the tissue, and that's where we get a different story. Those chronic injuries tend to have less acute pain and ongoing, lesser symptoms, and nothing completely resolves. So when we're most suspicious of an injury type of lesion is the classic presentation, recent onset. A lot of times the patient is aware of the injury and what caused it, particularly physical injuries. Chemical injuries, maybe not. They may not recognize the association with the chemical that caused it. Kind of depends on what chemical it was and why they were using it in their mouth. So history becomes important and is a good clue. We have our physical injuries that are going to be different patterns, cuts and scrapes. Scrapes can be superficial, broad abrasions. Cuts are usually narrow and deeper, although they can be superficial. We can get rubbing type injuries, harsh rubbing that may not break the surface but could produce kind of a blister or a sloughing kind of response rather than a typical cut off the surface. We can have trauma that's suction type trauma on the surface, blunt force trauma rather than a sharp cutting type of trauma, and then our thermal burns would be examples of physical trauma that cause injury. And I think the ones that you talked about with Dr. Grundy, this is her topic, linea alba, morsicacia bacarum, the fresh wounds like traumatic lacerations and abrasions, the traumatic ulceration, which is less fresh and has had time for a host response that creates the ulcer membrane on top, the submucosal hemorrhages. I think she also included some less common things like the injuries related to the cosmetic fillers and things like that. That's a little esoteric and not our bread and butter type of traumatic injuries, and so we're not going to cover that in our review. You can read about it. You'll never see questions on that on your national board next year. But patients do come in with weird things related to those fillers. Were there any other topics that you could remember she covered that are not on this list? The hemorrhages, the fresh wounds, traumatic ulcers, and the thermal burns. I think. Yeah. Did I not put up I didn't put up the thermal burns. Well, we'll do the thermal burns too. All right, so that's kind of what we're going to talk about with this one. Most of the traumatic injuries that we see in the mouth in clinical practice are the ones that are not fresh injuries. They are recent injuries where we've had time for a host response, so they do present as traumatic ulceration. And most of the time, it's not the reason the patient's coming into the office. It's usually they just happen to have an injury at the same time they had an appointment for something else and we happen to see it. And it's important that we recognize what it is and realize that it's not something more serious than just a traumatic ulcer that's going to heal on its own. Occasionally, these are lesions that bring the patient into the office. Most of our traumatic ulcerations are focal and solitary. What does that mean?
They exist as by itself.
exists by itself and usually localized, confined to a small area. Whenever we have patients that have extensive lesions or have multiple ulcers, we are not likely to be working with traumatic ulcers. It's possible, but those then usually come in with history of major trauma kind of thing. The hygienist isn't going to be working with those and recognizing those. So most of these are just kind of incidental, that they happened near the same time the patient was coming in for a dental appointment. Sometimes we have multiple oral ulcerations that do have to be diagnosed, and those are more likely to be immune-mediated or part of the manifestation of a systemic disease or related to some other type of chronic disease process. The only other cause of oral ulcerations that are solitary and focal usually are cancers. So anytime we see solitary ulcers, we always have to think, could this be related to cancer? And what are the signs about it that would make us suspicious that it's cancer? So what are those signs that would make us suspicious that a solitary oral ulcer is really an ulcerated cancer?
If it doesn't go away after 2 weeks.
Right, it's persistent. It's been there longer than 2 weeks.
Mm-hmm.
What else?
It doesn't heal?
Well, that's the same thing. It doesn't heal in 2 weeks. The time frame is important.
Mm-hmm.
Sometimes we see these things and we don't have a history. We don't know how long they've been there. The patient can't tell us, and that's when we have to observe them for 2 weeks to see if they heal.
Yeah.
Mm-hmm.
If the patient comes in and says this has been there for 6 months, I'm absolutely sure of it. We don't really need to go another 2 weeks to observe. We know it's been there a while. So we would be suspicious. Anything else?
Like the color, I don't know.
An ulcer kind of looks like an ulcer
Yeah.
that has that surface depression with a tan
Mhm.
bit, but there are other changes in the appearance that could be
Yeah.
suspicious.
Oh,
Is there
oh.
thickness or a mass effect?
Mhm.
Does it have a rolled raised border?
Yeah.
Is it indurated when you palpate it? Unfortunately, if we have repeated trauma and chronic injury, we can get rolled borders and indurated base just from chronic trauma. So those in and of themselves don't say for sure that it's a neoplasm, but they do make us suspicious. So what do we do when we have an ulcer that looks like it could be a traumatic ulcer, but it's been there confirmed for more than 2 weeks and it's not healing? What do we do?
Biopsy.
Absolutely. You send it for biopsy because you don't want to take any chances that it is a cancer. So those are important things to keep in mind.
Does the feel of it have to do, like if the pain goes away, like does that have to do with
That's I think an important clue too.
Okay.
If it's been there a while and there's no pain at all, that's a little more likely to be a cancer-related ulcer. However, ulcerated cancers can be painful too. It's just a little bit more likely. That doesn't tell us one way or another.
Mm-hmm.
And there are patients who have chronic traumatic ulcers that are completely painless.
Mm-hmm.
So
Yeah.
the absence or presence of pain tips the scales a little bit for suspicion, but again, doesn't give us all the answers that we want. That's a great question. Traumatic wounds that are fresh, we have names for them, and I think you learn the names. These are penetrating injuries or open wounds of skin and mucosa. The clean, straight cut type wounds are called incisions. If it's a little more irregular cut type wound or torn surface, that would be the laceration. And sometimes those are almost like an incision, a little straighter and more uniform in their shape, but sometimes they're very ragged and irregular, and so there's a lot of variation with those traumatic lacerations. Abrasions are the ones that are very superficial, just barely scrape off the epithelium, but tend to be broad, like when you skin your knee.
Mm-hmm.
And we can see abrasions in the mouth sometimes. And then puncture wounds are the ones that are very small at the surface, but puncture deep. They're deeper wounds that caused by something very small and narrow that goes deeper. puncture wounds caused by your needle, we wouldn't call a traumatic injury because we use such fine gauge. It really doesn't cause much of an injury. If somebody managed to stick a giant needle in their mouth, you could have a puncture wound. More likely to get a puncture wound from a pencil or a nail or some other sharp, round, narrow, thin object that they fell on or was holding in their mouth, working in the garage, and then ended up jamming in their tissue or something like that. So which of these is a fresh injury and which is a traumatic ulcer that's been there a day or two?
I think
The right one
The right one is which?
is the fresh.
The fresh injury. So how do we know it's fresh?
the color of it.
The color is red because there's hemorrhage.
Yeah.
It hemorrhaged where the surface was lacerated, and there's no tan. The ulcer membrane is that tan kind of color, and there hasn't been time for that to form. So the color is very important. You can also see the edge just hanging down. That hasn't had time to heal, so there's some good clues that that's a fresh injury. Would we call that a submucosal hemorrhage?
No.
Not really, because it's hemorrhaging out through the cut in the surface. Okay. So the one then on the left is our traumatic ulcer, and see the tan membrane in the middle? And it's depressed like an ulcer, so you can tell that the surface was disrupted. Is that a new one that's only been there a few hours? Or has that one been there a few days or almost healed like a week into it? What do you think? Can you tell?
Yeah, I feel like, yeah, because it's becoming the same color.
It's
as the-
becoming the
yeah.
same color as surrounding tissue. This
Yeah.
one's a healing one.
Mhm.
I think we're going to have to switch to my laptop. This I am not happy with this.
Mhm.
So let me see if I can just turn it off. And I don't know that y'all need to move. I can move.
Okay.
Yep, I can move. Works for me. And we could probably turn on the lights. If you need them a little bit dimmer. So I have a laptop with a pretty good screen and a pretty big screen and a pretty good resolution screen. Yes. I have to special order this, and they don't like faculty to have these big ones, but I
Oh, wow.
cannot live without my wonderful big screen. I love
Why
it.
is that? Why?
Because when I always have homework, I have to do a
Uh-huh.
lot of work at home because I don't have enough office hours to get everything done, and I usually have multiple files open, and
Yeah.
I just can't see enough of them
Yeah.
when I work off a
That
little
makes
screen.
sense.
So
Yeah.
for almost 6 months, I worked off a loaner laptop this year.
Oh, wow.
That, yeah, it took forever to get my new laptop. 13.5-inch screen. I thought I was gonna go bonkers with that little horrible screen. Anyway,
Yeah.
so we covered our different classifications, and this was
Oh yeah, you
our
can.
traumatic
do it.
ulcer versus our traumatic laceration. This particular traumatic laceration was caused in the dental office. It was iatrogenic, and it was caused by sharp edge on radiographic film
Wow.
before electronic sensors were used. And they had some paper covered ones, and it could cut when you place those.
And
in
you're
the
saying
mouth.
this was back?
That's an
Okay.
older case when we
Okay.
used to have that different kind of
Yeah.
film. Nobody even uses that kind of film anymore. All right. I don't know why that's doing the double thing. All right. 2 patients. Tell me what you think about them. Tell me what you think about the one on the left, because that should be very familiar to you.
Linea alba for sure.
You think so?
That's what I think, because it looks like a line. It can either be linea alba, depending on, well, just looking at it, it can be the
Say it.
Morshicacio
Buccarum. Morsicacio buccarum.
Mhm.
So it could be either one of those, but it's actually only one of the 2. So how do you know the difference?
by the history and like how
No.
much they cheat. Oh, so just like
You know by looking.
looking. Okay.
And then you could get the history that supports it.
Okay.
If you're looking for the story to tell the difference, you're not going to usually find it.
Okay.
Because most of the time, the patient is unaware of both of them.
Okay.
Okay?
I would say
So
there's like a line right there.
There is a
it's
line.
pretty distinct.
Yeah.
it is pretty distinct, but both of them have a line right there that's pretty distinct. So how
Okay.
do you distinguish between the 2?
It's the line is at the level of where they occlude.
But both of them are. So
Okay.
one is caused more by suction and the other is by chronic chewing.
Mm-hmm.
Both of those really produce changes right at the occlusal plane.
Okay.
So the difference is the character of the lesion, the
Okay.
extent and the surface.
Okay.
When it is due to suction, a person who kind of sucks a nervous habit or something sucks on their cheeks, we get the raised line, but it's nice and smooth and it's pretty narrow and uniform, and it is usually more light pink than it is white. But the surface is smooth, and it doesn't extend past the linea alba. I mean, past the occlusal line. So
Okay.
it's a narrow raised, smooth line.
Okay.
Okay? You can see a color change and you can see the elevation, but it's smooth. And if you ran your finger over it, it would be smooth. Okay.
Yeah. Okay.
When you have a patient who's chewing the cheeks, they get a callus effect. So there's some hyperkeratosis and they tend to chew the keratin and it tends to have a rough and ragged surface. And they can chew a wider zone than just that line at the occlusal plane. So it tends to be a little more broad, a little more irregular. And sometimes it's not the whole length even. It's just where they have a tooth that's malpositioned that it's easier to chew with. So it can be a little more localized to just like the distal half of the occlusal plane or the anterior part, but it tends to be broader and rough. So what do you think of this one?
For sure. Yeah.
Is it
Yeah. Yeah.
narrow and smooth,
No.
or is it broad and rough?
Broad and
It's
broad.
broad and rough. So this is definitely more Morsicaceobacearum.
Mm.
And
Okay.
she actually chews her lip too, so she's got some Morsicaceolabiorum as well.
And that's just usually like when they're nervous or just like.
It's a habit. It's a habit, and because it feels good. So I actually chew my tongue, true confessions, and it's hereditary. My dad chews his tongue,
Yeah.
but I didn't grow up with my dad.
Mm.
And it's like,
How did you find out?
you know, my parents were divorced when I was really little.
Yeah.
And I remember my dad chewing his tongue, but I never really thought about it. And I was well into adulthood before I realized I chew my tongue and, oh my goodness, my dad used to do that. So
That's-
I swear it's
yeah.
hereditary. It just kind of feels good. And it's always this side. But I don't just chew on it long enough to whatever, but I'll just chew and squeeze it. It just feels good. I don't know why. So somebody else, maybe when they chew their cheek, it just feels good. It's comforting.
Yeah.
I don't know.
Is it like, yeah, it's like a habit.
So
I don't know.
it becomes a habit. It can be a nervous habit. It can be a self-soothing kind of habit, whatever. But it becomes a habit. Does it require specific treatment?
No.
No.
Not usually, but patients need to be aware of the habit because with awareness they can break the habit.
Okay.
Okay. Is this one Morsicaceobacearum?
No.
Why not?
I don't see the same ragged surface and rough surface.
And there's something else that's really important.
It's
What
I
is
see.
the clinical pattern of lesion?
So I see like a little redness in there.
Yeah.
It might be like a puncture. from
Might be a
tooth.
puncture. But does that represent the whole wound or is that the exception to the general pattern?
I don't think it represents
This
the
looks
whole.
funny because this is a mirror view and this is the cheek where the mirror is touching it. So we're
Oh.
actually looking at the opposite side. But anyway,
Oh, okay.
yeah. So we don't see all the way back.
Oh,
In
okay.
case that's the edge of the edge of the mirror.
like,
It's a mirror
okay.
view. So it's a little
Oh, I get what you
disorienting.
mean. I get
Yes.
what you mean.
But what is this? So you talked about the little red spot, but what is
I
this?
think it might be
Like
like
a
some
ulcer.
Not an ulcer. It's
Right.
an ulcer. So an ulcer involves a break in the surface.
Mhm.
We only get an ulcer when there's loss of surface epithelium and we have an inflammatory host response.
Mhm.
Morsicaceobacearum does not break the surface. We chew and irritate and rub on the surface. That produces hyperkeratosis and kind of pulls some of the keratin off, but it is not a penetrating type of injury.
Mhm.
Whereas an ulcer is a penetrating type of injury.
Mhm.
Or maybe it's immune destruction of the epithelium, maybe it's traumatic destruction, but there's loss of epithelium and an inflammatory host response. So the clinical pattern of the lesions is vastly different.
Mhm.
It is just one So what
Yes.
is the most common cause of or diagnosis for a solitary focal ulcer?
Oh,
We just talked about that.
Cancer? Or, well,
Most common
the
one
most common
is,
is a traumatic ulceration.
yes, traumatic ulcer.
Ulcer, okay.
But the thing we have to be concerned about is the possibility of an ulcer over cancer. That would be the second
Okay.
most common.
Right, okay.
But traumatic ulcers are actually a lot more common
Mm.
than solitary ulcer over a cancer.
Mm-hmm.
So we talked about ways that we would be suspicious for one or the other.
Mm-hmm.
So we need a history, don't we?
Mm-hmm.
yeah.
So what if I told you that this patient was in the dental office yesterday, didn't have this lesion, and became aware of this lesion a few hours after the appointment, when the numbness of the cheek wore off?
Okay.
Oh,
Traumatic
yeah.
ulcer.
Yes, it's a traumatic ulcer.
Oh, okay.
So is it iatrogenic?
No, because he bit his own.
He bit his own cheek. Yeah, the
Yeah.
dentist didn't bite his cheek.
Right.
Just happened to be numb and he couldn't feel that he bit it because
Uh-huh.
it was numb, but it was an accident. He accidentally bit his cheek while it was still numb.
Mm.
Or she. I think this one might be a she.
Mm-hmm.
So, but that's a beautiful traumatic ulcer. And you can see the puncture, you are absolutely right. But the important part, the diagnostic part, is the traumatic ulcer.
Mm-hmm.
Okay?
Yeah.
So how are you going to treat this one?
Just no treatment because
Tincture of time.
Yeah.
Mhm. Yeah.
Just naturally should
Yep,
go
it
away.
should heal on its own and it should be gone in 2 weeks or less. This size might be close to a week because it is a little bit bigger.
Mm.
That's a beautiful traumatic ulcer. We're doing all the double names.
Yeah.
All right, patient on the left is a new patient who comes in wanting dentures because her dentures don't fit very well and it kind of hurts when she wears them, and when the dentist examines her for her new denture examination, finds this lesion. Where is the lesion?
Right or left again?
Do you see it? Do you see the lesion?
On
Oh,
the-
the one on the
Soft
left,
palate.
the one who has no teeth.
Right there.
Yeah.
So,
So there's one here and maybe a smaller one here. It's hard to tell.
mm-hmm.
Patient complains of pain when she wears her denture, but that's just been an ongoing problem.
Uh-huh.
So what kind of diagnosis would you consider for that?
She would be-
Recurrent aphthous stomatitis.
No.
Does that typically occur associated with a denture?
No.
Oh,
No.
okay.
Think of the location too. Is this on hard palate or soft palate?
It's on the hard palate.
It's really on the hard palate
Oh.
side of the junction.
Okay.
Would we get aphthous stomatitis on hard palate?
No.
Nope, we would not.
Okay.
It's only unmovable.
It's unmovable mucosa.
Mhm.
Absolutely.
Yeah. And so then that one, because it's due to a denture, it has to be, the name was just coming up. Lichnoid? No.
No,
No.
that's a
That's also, isn't that also traumatic?
Yes,
Okay.
it's a
Oh.
traumatic ulcer because her dentures don't fit.
Okay.
But recognizing that it's depressed on the surface and it has a kind of thin ulcer membrane instead of a thick one.
Mhm.
But you see the kind of tan ulcer membrane? So
Yeah.
recognizing that it's an ulcer is really important, and the story that goes with it supports that it's traumatic.
Mhm.
Dentists like to call those denture sore spots. We hate that term. It is just a denture-associated traumatic ulcer. Okay.
Mm.
Patient on the right, in the office for a routine dental appointment, but reports that there is tenderness of less than 24 hours duration on the anterior palate. So
Okay.
this is the back side of the incisors right here.
Okay.
So we only have a partial view, mirror view, hard to kind of get a good picture of that area.
Okay. Um,
Would it be?
so this is due to a denture? Yeah.
No,
Or, oh,
Is it like a
dentures
bruise?
usually sit there.
No.
wait,
There are teeth, we have teeth.
Yeah.
There's some missing teeth, but this is not
Oh,
a patient
oh.
who wears a denture.
And it's due, and it happened after the dental appointment.
No,
No.
they're in today for their dental appointment,
Okay.
but the tenderness has been there just basically since last night.
Okay.
Is it another, the same one? Traumatic ulcer as
Do you
well?
see an ulcer?
No,
No.
there's no
See,
ulcer.
our ulcers are nicely
Yeah.
defined and depressed with a tan membrane. And how would you describe that?
Just like
Abrasion?
little dots everywhere.
It's kind of mottled red and white.
Yeah.
So it's red areas and a little paler in between.
Okay.
So the red, what do you think causes redness in the mouth?
Irritation? No.
Well, what disease process in the tissue usually produces redness?
Metal.
You're thinking
No.
of
Yeah,
etiologies
yeah.
and I'm thinking of disease processes.
Just diseases.
Disease processes, I'm thinking back to general pathology topics.
Oh, like necrosis?
No, inflammation.
Inflammation.
We get that hyperemia when we have inflammation, acute inflammation.
Uh-huh.
And dilated vessels bring more blood, it turns red. So we
Okay.
have some erythema from inflammation. That's the most common cause of redness. It's not the only cause of redness, but the most common one is inflammation.
Okay.
So what might be producing inflammation that just happened since last night and have some redness and tenderness and mottled red and white color? Can you think of anything in our
No.
category that we've studied that in our two category, in our,
And both categories.
Like would it could be like maybe something she ate that caused maybe
caused what?
um
What would something you eat do that would produce inflammation?
so like I'm thinking like having like an allergic reaction to something.
Possibly,
Okay.
possibly.
Or something.
This doesn't itch, it's only tender. Allergic
Okay.
reactions, we would expect some itching and some maybe manifestations somewhere else.
Mhm.
That's certainly something to think about.
Okay.
What else? Something you eat, what could it do? It could produce
Yeah,
inflammation.
a thermal burn type of thing.
We could have an injury from our
Yeah.
food. Now,
Mhm.
we don't usually get traumatic injuries from food, but sometimes people will bite on a bone when they're eating like ribs or chicken wings or something. And
Yeah.
so you can get some puncture kinds of injuries.
Yeah.
Those are very uncommon to have traumatic injuries,
Okay.
physical injuries.
Physical
But
injury.
thermal injuries from food are very, very common.
Mhm.
Okay.
So what kind of foods usually produce burns right in that anterior palate? Pizza,
Uh-huh.
those are often more severe than this
Oh, okay.
because they
Yeah.
really burn and it already is
Yeah,
sloughed
me
by
too.
now.
Bread.
We've all done it,
Yeah.
all done it.
Mhm.
So what else?
Bread? No,
Bread?
that's the same thing as pizza. Yeah.
Something microwave like
Microwave like soup.
like soup, yeah. Or
So hot liquids.
Hot
that we
liquids.
sip- hot soup or hot coffee
Mhm.
or tea, that's the area you get it usually.
Mhm.
So
And that's the palate.
anterior hard
On the anterior
palate. So
hard
this
palate,
is the
okay.
rugae and
Yes.
this is 8 and 9
Mhm.
lingual side.
Okay.
So that fits beautifully with the thermal burn.
Mhm.
But recognizing it, I think, is important and thinking about what it could be, because then you can ask the patient, well, what did you eat last night? Oh man, I had this wonderful pizza, but I bit into it when it was too hot.
Okay.
They'll tell you.
That helps a lot because a
Mhm.
thermal burn usually turns white after a certain
It's
time.
white pretty
Right,
quickly from
okay.
the coagulative necrosis on the surface, and then
Okay.
it'll slough.
Okay.
And sometimes they slough pretty quickly, and sometimes they take a day or two to
Okay.
slough.
Mm.
I had a burn recently, and I didn't have anybody to take a picture of it, and I thought, I have missed a great opportunity for a test question. It's a beauty. It's
Mm.
like, and I know better, but did it and got it anyway.
Mm.
All right. Does this one look familiar?
Yeah.
Yeah.
Push the button already. So, traumatic laceration, irregular cut-like wound. We know it's fresh because it's got hemorrhage associated. So
Mhm.
we know it's a new one. It's not an ulcer. It's not something that's been there hours to days. So this
Okay.
was the one on our quiz. Did you
Mhm.
get traumatic laceration on your quiz?
Yeah.
Good job.
That was close.
All right. Two different patients. Patient on the left. Story on the patient on the left is that the patient came in 2 days ago for dental treatment, had a long buccal injection, went home with a pretty numb cheek, and noticed later in the day that the cheek was a little bit tender, but not any big deal. And is returning today for continuation of treatment, did not come in for this, just happens to be there.
Okay.
to biting.
Due to biting, can't you
Yeah.
see the cusp tips?
Yes.
So the question is, did the bite break the surface or not?
No.
Nope. So what diagnostic term applies to this type of injury?
So if it's just biting, my guess is just
So,
no.
Is-
It's because it's
is
not
this
constantly.
morsicaceoe bacterium from
No.
chronic biting?
No.
No, and there's no white component.
No.
So it was an isolated incidence of biting trauma
Yeah.
that has produced what type of injury? Why is it red?
Submucosal hemorrhage.
Puncture?
It's because of the hemorrhage. So, bit hard enough to break the blood vessels under the surface, but not
okay.
break through the mucosa.
Okay, so it's
So, what diagnostic pattern of submucosal injury applies to this size?
I would say not pura,
Purpura?
purpura,
Purpura at least 3 millimeters, 3 to 5 millimeters.
and that's about no. Yeah.
Most of these are
bigger.
smaller.
Yeah.
No, these are little small ones.
Okay. So,
So
then that one
Oh, ecchymosis is big.
It's and
Bigger
then
than
hematoma
purpura.
is bigger.
And with
yeah.
swelling.
Okay.
So what's
then
the littlest one?
Petechia.
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 I
Petechia.
need
Part
to
of our goal is
practice.
to learn how to say these.
No, I'm
Mhm,
lazy
yeah.
to
Oh,
learn. Yeah.
my D2
Yeah.
students are in general and systemic path, and they ask me questions and they butcher the terms too. And we have to all learn how to say them. They're kind of hard.
Yeah.
Yep. So those are
Okay.
petechia. Those are nice petechia.
Okay.
Yeah, okay.
They were a little bit bigger. We'd start thinking about purpura, but
Okay.
those are petechia. Okay.
Yeah, okay. Because with petechia, I thought they were like smaller.
They're smaller, but they're not all teeny pinpoint. But they
Oh,
are the
okay.
smaller little focal ones. So 3 millimeters would be about that big.
Mhm.
I would still call these petechia.
Petechia.
Yep.
Okay.
Yep. Some of them look like they bit more than once. This is a bite next to another bite.
Mm.
So that makes them look a little bigger, but they're pretty little. Okay.
Mhm.
So those are petechia. What about this patient? So this is a patient who's at the dental office, had 3 teeth prepped for crowns, and those are horrible tin can temporaries that we realign with acrylic. We have much better materials now.
Mhm.
But the mucosal changes were noted at the end of the appointment.
After first stomatitis recurrent.
Would those lesions appear during the course of a dental appointment? No. And those would be
Oh.
ulcers. Do you see ulcers there?
Yeah, no. Oh, wait, I
You
see.
do? What do
oh.
you see?
Okay, so what I see is because you said that they caught it last at the end of the appointment.
They
so-
saw it at the end of the appointment, but it wasn't there at the beginning
Oh,
of the
okay.
appointment.
Okay. Oh,
This-
so it happened. during-
This is something that just developed. It
Is
was a
this
long appointment.
Okay, so then it's an
Long
allergic
appointment, because it takes
reaction.
a
Yeah.
while to prep 3 crowns and
Right.
take
Yeah.
impressions and
Yeah.
make temporaries, and
Yeah.
so that was a long appointment.
Is that lichenoid contact stomatitis?
Now, the immune-mediated things take longer to
Oh,
develop, so
okay.
we would not expect anything immune-mediated.
Okay.
So
it's more of a like contact.
How would you describe what you see?
little, small little. No.
Are they little ulcers?
No.
Are they innies or outies?
Outies.
They're outies. They're little elevated areas, and then this looks like it's peeling right there. You see?
Yeah.
One little part
Okay.
looks like it's peeling, but the rest of it, they look like little elevated, pale somethings.
Mm-hmm.
I don't know if you saw anything like this in class with Dr. Grande, because she lectures on this topic.
Mm.
It's something I hope you never see in practice.
Oh,
You don't know? Guessing?
yeah, I'm gonna. No, I don't.
Go ahead.
Because I think it might be. Oh, he said it already, actually.
What?
Lichenoid.
No,
Yeah,
it's
but
not
then you
immune-mediated.
said
Yeah,
that-
no.
No.
So then-
This is an injury that occurred during the course of the dental appointment, a long dental appointment. A little bit of sloughy stuff
Oh, wait.
and outies. Almost look like little blisters.
Are those?
Maybe come. No. I have
Hmm.
no idea.
So
I don't want to spend too much time on this.
Okay.
This is a cotton roll burn.
Oh.
This is the
Oh.
kind of injury you get when you put a dry cotton roll on the tissue and you don't wet it down before you pull it off.
Okay. Yeah.
So
Okay.
it desiccates the tissue, sticks to the tissue, and produces very superficial injury, often looking like little blisters or just ripped off that very superficial layer of epithelium.
Oh.
And we call them cotton roll burns, I think, because sometimes it looks like little blisters where it pulls up,
I see.
where it had desiccated the tissue. So that's really easy to prevent by wetting down your cotton rolls before you remove them. But most of us at some time or another have caused one of these. Sometimes we call them traumatic erosions, but the common term is cotton roll burn.
So it would just.
What
be
is an erosion? Where you just remove a portion of the epithelial layer, but not the full thickness, so you don't get an ulcer. You just lost a little bit of the superficial part of the epithelium. So it stuck to the cotton roll and got pulled off.
Okay.
Okay. This is a lesion that developed during a dental appointment. You can see the appointment is in progress. They are prepping this tooth for a crown. You can see amalgam that's been flying all over the place. This is a mirror view. This is the actual tooth. But what term would apply to this lesion that appeared during the course of this long appointment?
It could be iatrogenic.
Oh, it's definitely iatrogenic. But what diagnostic term would we use for that lesion? Does it look like a physical injury?
Yes.
Yes, and it looks fresh because there's a little tiny bit of blood, and it's an innie, so it.
Oh,
It has to do with
like
the instrument.
Like an abrasion.
Yes.
Okay.
Scraping the surface, removing part of the surface, got a little hemorrhage there, but there's not a tan membrane yet because it
Right.
hasn't been there long enough for the host response. So that would be a traumatic abrasion, and that was actually done with a high volume suction tip, scraping along.
Okay.
Yeah.
That's usually an accident. Just.
Oh yeah.
Yeah. Okay.
It's an accident.
Okay. An accident usually.
Yep. You gotta be. Some of those. I think a lot of our suction tips are a little bit better. You can get the soft edge ones now, so you're less likely to traumatize the tissue. But the cheap ones that are affordable, they kind of have a pretty sharp edge to them, and they can cut the tissue. So we like to keep them off the tissue because they do tend to abrade. All right, this is totally different kind of a thing.
Ecchymosis.
That fits with ecchymosis in the middle, where it's all blending in. What would you call this part at the edges? Petechia.
Petechia.
So the petechia can coalesce and form purpura and even ecchymosis. And lots of different things can produce submucosal hemorrhages in the soft palate. I think Dr. Grande reviewed that with you very carefully. Coughing, chronic allergies, and clearing the nose, trying to breathe because of your allergies. Even frequent morning sickness with vomiting in pregnant women can do this. Infections can do this. Which infection is known for doing this?
Like fungal infection? No.
Petechial hemorrhages in the soft palate with fungal infections?
No.
No.
Okay.
But there's one infection that's famous. 25% of patients get petechial hemorrhages in the soft palate.
Is that because of it's due because of us, right? Is it because we do it to the patient?
No.
Okay.
Infection. We're just talking about infection.
Oh, just a general infection.
Yeah, just infection. What kind of infection is known for having palatal petechia as part of its soft palate petechia as part of its manifestation?
Sore throat.
Has a sore throat with it too.
Okay.
You know which one it is. Not strep throat.
Okay, never mind.
Not strep throat. But you're on the right track.
Okay.
It's often misdiagnosed as strep throat.
Okay.
You do not want to treat it like strep throat or your patient will get very sick.
Is it just a regular
It's an ordinary virus.
the flu?
Nope.
Oh,
Don't remember?
Kaposi? No, that one.
In the right family, wrong virus.
Oh. Right.
I
Like HIV? No, HIV.
Oh, no. HIV is not in the same family of viruses as Kaposi sarcoma. Kaposi sarcoma is associated with herpes virus type 8, human herpes
Right.
type 8.
Okay.
So this is one of the herpes family viruses that does this.
Okay.
A very, very common.
Okay.
Don't you give?
Yeah, I get.
Yeah, me too.
Infectious mononucleosis.
Oh, okay.
They famously
Infectious.
get palatal petechia,
Okay.
and that's caused by Epstein-Barr virus.
Mm.
What is it called again?
Infectious mononucleosis, mono.
Oh, mono.
Mono,
Okay, yeah, now I
yes,
know.
mono.
Okay.
And you said that causes
And
PT.
the pattern of change here was ecchymosis with petechia at the change. But it
Okay.
usually starts with petechia, but they can enlarge and coalesce.
Mm.
But that's a patient with, this one was a mononucleosis patient.
Uh-huh.
All right. We had a nice discussion earlier, and we should know
Yeah.
exactly what the diagnosis is for each of these patients based on our earlier
Okay.
Yeah.
discussion.
M-
So,
Morsicatio bacarum
for
this
Yeah.
one?
absolutely, but see how it's rough and
Yes.
broader?
Yes.
Now we see that.
Yes, and then the one on the right,
Linea
Linea
alba.
alba.
linea alba. It's elevated, it's a little paler, but you can see it's smooth.
Mhm.
It undulates a little bit, but it's smooth. It doesn't have that rough, ragged
Right.
surface.
Mm.
So you can tell by looking, you don't have to have a history that tells you what it is.
Yeah.
Mhm.
I gotta get rid of the double things. This one we already looked at.
And that one was because a traumatic ulcer, right?
No, it's too fresh.
It's too fresh.
So it's because it's just got hemorrhage but no ulcer membrane. So it's one of our fresh wounds. Remember what it was? We just looked at it. a few
Yeah, I
minutes
know.
ago.
That's what I'm trying to do.
Okay.
Remember.
Yeah.
So we want to think about how this one is different. You don't remember what we called it?
Oh, it was like
What do we call it?
a traumatic injury. Or-
No, that's a category.
Oh, okay.
The specific diagnostic term that applies to a fresh
Oh.
traumatic wound that's got a linear cut-like pattern.
Oh, laceration.
Yes. So that's our
Okay.
traumatic laceration.
Okay.
This one, no laceration.
No.
No bleeding out.
No.
But this is a fresh lesion. It's only been there a few hours. It appeared during the course of a long dental appointment. It's got a little depression like a moat around it. There's a reason for that. And do you see the reflection?
Mm-hmm.
And the reflection, this is elevated.
Mm-hmm.
It's firm. It does not blanch. It is a,
Hematoma.
absolutely. So you want to hear how it got there? I think Dr. Grandi uses this in class, but she doesn't know the story behind it. She hasn't been here for 100 years. This was a patient who was having a long dental appointment where they used a sphedopter, which was it's a special kind of suction device that hooks to your high volume suction and it holds the tongue away.
Mm-hmm.
And then it has an exposed part of it that picks up the saliva. And it wasn't positioned correctly, and the open part that was supposed to just pick up saliva was sucking on the cheek
Oh.
for like 2 hours.
Oh, wow.
Yes. Yes.
Jeez.
I have a picture somewhere in my files of the sphedopter that caused that, but it has this little round-like opening that just is this shape. So that's where the metal, the moat around it, the depressed area was where the ring of the suction tip thing was
Yeah.
pressed right on the tissue. Yeah, you have to
Wow.
be careful with those.
Yeah.
Yeah.
And that's our laceration. Okay, what else do we have? Oh, something else we've seen earlier today.
Yes.
The one on the left. So you know the
Okay.
story on this one. This was a patient who went to the dentist yesterday or day before. I've already forgot the story I told you. It was yesterday or day before with a toothache.
Yeah.
And the dentist placed a temporary restoration, rescheduled the patient to come in later for a definitive restoration. In the interim, this lesion appeared on the gum tissue and it's very tender. So, what diagnosis did you select for the lesion on the gingiva?
Knowing that it was the day before, it wouldn't be lichenoid because that takes time.
And that would that would be immune mediated.
Mhm.
The first thing to do is think about the clinical pattern of lesion. So do we have white streaks and lacy surface changes, or is this a different clinical pattern?
Different.
clinical-
Different. So what is the clinical pattern? How would you describe what you see? If you can describe things accurately, you can usually figure out what they are. And that's always the starting place. Describe it in your mind's eye.
Okay. I see sort of a mass,
Inflammation.
or
There's some swelling there.
swelling there.
Yes.
Okay.
There's definitely some swelling of the gingiva. And then what's
Okay.
right next to the area of swelling?
Is
The,
ulcer.
Yeah, there's an ulcer.
Yeah.
It's swollen on the either side of the ulcer.
Mm.
also the
So,
ulcer would be.
This is the ulcer.
ulcer.
It's depressed and it
Okay.
has that tan surface membrane.
Hmm.
So, now that you've described it so beautifully, you can make a diagnosis.
Traumatic ulceration.
Yes.
Okay.
See, that was easy.
Hmm. Okay.
You want to venture a guess how it got there?
Maybe.
Patient due to patient.
No, I would say it was iatrogenic. Yeah.
Good observation.
Mm.
How?
So, this dentist had very good local anesthesia on board and used a rubber dam and actually placed the rubber dam clamp teeth on the tissue instead of on the tooth. You're supposed to slide it down on the tooth so it's tooth-borne.
Yeah.
Mhm.
And the patient didn't know that it was on the tissue because it was numb.
Yeah.
So during the entire appointment, to place that temporary restoration, it was digging into the tissue,
Oh.
producing the traumatic ulcer.
Yeah.
And then the swelling around it and the redness is from the inflammation, part of that host response to the loss of surface epithelium.
I see.
So dentists have to be careful how they place those rubber dam clamps.
Mm-hmm.
Yep.
Just a question. So, did you say that?
But do you
That
have
one-
to know that it was rubber dam clamp? No,
No.
you just
Mhm.
had to figure out it was a traumatic ulcer.
Yeah.
Based on that fits the history, and we see an ulcer type lesion that's fresh and just appeared, fits best with a traumatic ulcer.
Do ulcers take a longer time to form than a fresh?
The ulcer membrane, that tan layer,
Yeah.
is from fibrinopurulent exudate
Okay.
that collects on the surface,
Mhm.
which is part of our acute inflammatory host response,
Mm.
which takes a few hours to get rolling and to have enough blood proteins leave the vasculature to collect on the surface.
Yeah.
So it usually takes at least 4 hours to get an ulcer membrane.
Mm. I see.
And depending on the size, might take a little bit longer, but it does take a few hours.
Mm.
Within 24 hours, you can have a really good, well-formed ulcer membrane,
Mm.
but you're not going to see it 1 hour later.
Right.
There's just not enough time.
Yeah. Yeah.
Yeah, it does
Mhm.
take time. All right, so that's a beautiful traumatic ulcer. Do we see a traumatic ulcer in this patient?
No.
So this patient was also at the dentist yesterday and comes back to the dentist today complaining of pain with opening.
Okay.
Mhm.
So this happened after.
Yeah, the day before.
Day before.
Yeah, and ever since that appointment, it hurts to open. Feels a little swollen and it hurts to open.
Okay.
What is the term that we use for pain with opening?
Trismus?
Yes, patient has some trismus.
Mm-hmm.
Okay, what do you see? How would you describe what you see?
Redness.
And
Maybe
Palate.
submucosal hemorrhage?
it's red here and blue here, so it involves this whole zone, meaning
Oh.
it's kind of big. And is there anything important that might happen in this area during a dental appointment?
I'm thinking the suction. Could have
Do we
been
usually
there.
suction
No,
in
no,
that
no, no.
pterygomandibular raphe area? No.
Maybe injections?
Oh, just-
Injections!
yeah.
What injection?
The IA.
IA?
Mm-hmm.
PSA.
Well, and lingual too.
Yeah.
Mm-hmm.
So that's right on your landmark for
Right.
your IA
Yeah.
Mm-hmm.
insertion. So
Mhm. So that.
when you put 2 and 2 together,
It's a
what-
bruise. It's a
it's a bruise.
hematoma.
It's a hematoma.
Hematoma.
There's a component of swelling with it. It's got a mass of blood that came to the surface. So that's a hematoma.
Mm.
So when I was in dental school, one of my classmates' name was Mona. And her clinic partner that we practiced injections on was her best friend from undergrad. And Mona gave her classmate, our classmate, a huge hematoma with the PSA.
Oh.
I mean, her whole face was swollen. It turned purple. I mean, it was textbook. We should have published it. It was so bad. So everybody in my class forever after called them monatomas.
No.
Monotone.
Isn't that terrible? They're monatomas.
Wow.
It was so sad. It was bad enough to cause it when you're learning, but to
Yeah.
cause it to your best friend, it's like it was so sad. It was just very sad.
Oh.
I feel like I would have only gotten that it was hematoma if I saw this, but now that it was I don't know. Because every time I think of a hematoma, it's like blue or purple.
So the color depends on how thin the tissue is over it
Okay.
and how much tissue is between you and the mass of blood.
Okay.
If it's a little more tissue, they tend to look bluer, and if there's less tissue, very thin mucosa, it's more red.
Okay.
Mhm.
That's
Same patient, with and without the denture in place.
Traumatic ulcer?
Yep. And it is definitely associated with a denture, and although it is not the topic of the day, what do we call for this little area of excess tissue on either side of that denture ulcer?
excess. Oh, okay.
Buccal excess? No. It's not that.
Yeah. No.
Associated with a denture?
Oh,
The little bilobed thing that comes up around the denture that wobbles all the time? Do you remember?
Yeah, I know. I remember.
But you don't remember
yeah,
the name.
the name I don't.
yeah.
Because it's like extra.
Notice how it has a groove or fissure in the middle where the denture
Oh,
flange is?
epulus fissuratum?
Yes,
Oh, yeah.
epulus fissuratum with a traumatic ulcer right in the base of the little fissure that was caused by the denture.
Mm.
Whoa, what do we think of this one?
Definitely a traumatic ulcer.
Definitely. So what if
or-
I told you that that's been there for 18 months?
Oh, then
Oh.
then it would be a different diagnosis.
Yeah.
Maybe. Couldn't it still be a chronic traumatic ulcer?
Yeah, it could be.
Sure, it could be,
yeah.
but what else do we also worry about?
That it's on the side of the tongue?
No,
Oh.
diagnoses.
Oh.
What do we get concerned about when we have an ulcer, a solitary ulcer, and it's been there a long time? We had this,
Right.
that if it's not a traumatic ulcer, then it is
Then it's
cancer.
Yeah.
It's an ulcer associated with cancer.
Yeah.
And something being there 18 months, we definitely worry about it. This one has white around the edge from a little frictional keratosis, and it's got a firm rolled border. And see how the difference in color, this is tan and that's white?
Mm-hmm.
Yeah, it's nice to see them side by side.
So this would be a
It could be a
chronic.
traumatic, it could
Okay.
be a chronic traumatic ulcer, or it could be cancer.
Okay.
So this one, with that history that it's been there that long, this one actually had been present for 18 months, you would immediately send for a biopsy. You wouldn't wait 2 weeks to see if it goes away. But this was a chronic traumatic ulcer, and the reason for the chronic biting was the missing teeth. The tongue would kind of spill into that space and get caught all the time. So it can happen. But boy, that is very suspicious. So when we do our differential diagnosis for a persistent solitary ulcer, the two things that have to be on it are traumatic ulcer and squamous cell carcinoma with ulceration. What do you put first?
Traumatic ulcer.
Yeah.
Why?
Because that's the most likely diagnosis.
Because it's most common.
That's most common.
Right. So that's why it's first, because it is much more common.
Okay.
And then the other one is second. Good answer.
Okay.
Yep.
Yeah.
Yep. And our standard of care is if it doesn't heal within 10 days to 2 weeks, it does have to be biopsied. If we have a confirmed history that it's been present way longer than that, we would send immediately for biopsy. Okay? But if there wasn't a history and the patient didn't know how long it was present, you would try to eliminate any source of injury and then wait the 2 weeks and then biopsy if it was still present. That's our standard of care. Chemical injuries, what time is it getting to be?
one with me.
2:15.
Clocks. Do we need a break, or are we doing okay? You want to go straight through, or need a break?
Are you good?
I'm good.
I'm
yeah.
good too.
All right.
Yeah.
Then we'll go a little longer. If you need a break, stop me and we'll take a little break.
Okay.
So chemical injuries. Chemical injuries are caused by the caustic or toxic effects of the chemical affecting the tissue, and destroys tissue because of that. Has significant irritant effect. There are lots of chemicals that patients can put in their mouth that can cause injuries. It is really important to remember that most of the time that patients get chemical injuries, they were actually trying to self-treat something, and they were trying to do something good in their mouth. They just used something in an incorrect way. They left it there too long, or it wasn't designed to be used that way, but they didn't mean to cause a problem. Regardless of the clinical pattern of the lesion, when it is a chemical injury, the diagnostic term is something burn. We call them burns. Even if they look like an ulcer, the diagnostic term is still a burn. Okay, those are just the rules.
Okay, so like
And
an aspirin burn.
Aspirin burn, if we think it was caused by aspirin, we call it an aspirin burn. If we think it was caused by hydrogen peroxide, we would call it hydrogen peroxide burn, whatever. So we call it a burn. And you should be able to guess an appropriate chemical based on the context of the situation. Because usually for testing purposes, we are not going to tell you, this patient put an aspirin here. You have to read between the lines. So aspirin is usually used to self-treat something that's painful. So if they have a history of pain, particularly toothache, it's probably an aspirin burn, or something else they would use for pain locally. If it's something else, some other story, they were doing something else, who knows?
Whitening.
The whitening products are an issue. The hydrogen peroxide can be an issue for patients with periodontal disease, and they think they're really going to get rid of the bacteria in their mouth and help their gums by using lots of peroxide, but they use too strong a rinse and leave it in too long. So patients manage to do all kinds of interesting things. Okay. So chemical injuries do cause coagulative necrosis of the superficial layer of the epithelium. So it turns white because it's necrotic, and then sloughs off. So early on, we see the white opaque look, and then as the tissue moves and stretches, it cracks and then sloughs off. So the typical presentation is the sloughing, some white still left, and maybe red eroded surface underneath where there's some inflammation from the host response. This is one patient. Do you believe me if I tell you that the patient has pain and has a toothache?
Yes.
Probably has more than one tooth that hurts. Yeah, because you can see it. This is a pretty extensive lesions. This part is white with the little cracks. This looks like ulcer membrane. Then a little bit of the white with the red background on the tongue. But everything was on this side of the mouth. So what do you think that one was?
Probably, for sure, chemical burn. But specifically.
But we want to always put the name of the chemical we think it is in the diagnostic term.
Maybe an aspirin burn.
Maybe an aspirin burn.
Because they probably put it right.
Probably did. So this was a patient. Those famous patients who get toothaches on the weekend and think they can't call their dentist till Monday, kind of a thing. Over a two-day period over the weekend, sucked on 40 aspirins. 40. I can't figure out how come he didn't get some aspirin toxicity from absorbing it. I mean, that is just way overdosing on aspirin, but it was 40. That's a good question.
Because of pain?
Yes, and patients think, and I don't understand why, they think if they put it right next to the tooth that hurts, it will work better than if they just swallow the aspirin. So part of our job working with patients is to teach them how to use things properly.
Yeah, that's true.
And other than that, they might need some palliative care for really bad aspirin burn until it completely heals. But like warm saltwater rinses and appropriate pain management, which would not be anything topical at this point. I wouldn't let them take any more aspirin either. Let's do some Tylenol and give the body a chance to metabolize all that aspirin. All right. These are two similar but different patients. Both have a little sluffy and some white, and some sluffy.
Mm-hmm.
This has a normal pink background. This one has a red background.
Uh-huh.
This patient complains of a toothache. I'm pretty sure that's the tooth.
Yeah.
This patient, no toothache, and says this happens pretty often. Notices it in the morning but can't figure out what's causing it.
Oh. No.
So which one do you want to play with first? Left or right?
I think that this one would have to be like an aspirin burn because there was like a toothache involved. So
Mm-hmm.
they were trying to do that thing again.
So if on your quiz you chose aspirin burn, I'd be very happy with that. Unfortunately, that wasn't the chemical that this patient picked.
Mm-hmm.
They picked clove oil, which has topical anesthetic properties,
Oh.
but is a volatile oil and will burn, and they just overdid it.
Okay. So
Oh, okay.
Yeah.
Well,
But if the patient doesn't tell you that, I would assume it's aspirin until you get a good history.
Yeah.
mm.
So we're not going to count you off
Okay.
for what chemical you choose as long as it's in an appropriate category
Of burn.
for the patient's story.
Mm.
So I'd be thrilled if you thought that was an aspirin burn. It just didn't
Mm.
happen up being aspirin. They chose something else to
Something
relieve
else.
the pain.
Mm.
The other chemical that we see sometimes is Anbesol, or
Aerosol.
it's a little stronger than Oragel. It has phenol in it, and if you use it too frequently and too much, it can burn the tissue too.
Mm.
So you can get phenol burns from Anbesol.
Mm.
Oragel.
I see.
This doesn't fit that kind of a thing because
No.
there's no history of pain, and this is a recurring every few days. I notice this.
Few
In the
days,
morning.
every
In the
curve.
morning. And it's similar on the other side, the other cheek. We just have a good picture of it on this cheek.
And it's on right there.
And it's
correct?
filmy
Yeah.
there.
Yeah.
And you can see an edge to it here. And this is more pink, and this is a little more white. So
Mhm.
this already sloughed.
Maybe he was like sucking on something.
No.
Does
Yeah.
sucking cause sloughing?
Oh no, it doesn't.
No.
Maybe it's
So
just
you
a-
can see it peeling off right in front of you. And it's that really white peely off that fits with the coagulative necrosis.
Mm-hmm.
But it doesn't hurt
Okay.
because it's very superficial.
Okay. Do all burns hurt?
No, not necessarily. Depends how deep they are.
Okay. Was he trying to whiten his teeth?
No,
Okay.
he was not.
Hmm.
The tooth whitening things don't usually get onto the cheeks.
Okay.
We usually get burns right on the adjacent gingiva if it's tooth whitening.
Okay.
Sometimes it can get further out. It depends what they use, but not usually onto the cheek like that.
Yeah.
It's usually close to the teeth.
Hmm. Let's see.
I think it's important that the patient says this is happening every few days. It's
Yeah,
it's a
it's
repeated kind of a thing.
Okay.
Oh.
So what kind of things do patients routinely and repeatedly put in their
Brush your
mouth?
teeth,
Toothbrush?
Toothbrush, toothpaste.
Yeah.
Okay.
Do
So
Yeah.
those
So-
produce sloughing?
No. Wait. Oh.
Toothpaste sometimes.
Oh, so it
Strong
does-
toothpaste
okay.
can.
mm.
I thought okay.
What else can?
The way they brush their teeth, maybe? No, not that.
That would be a physical kind of a
Yeah.
thing. And toothbrushes wouldn't do that on the cheek.
So I'm guessing maybe the mouth rinse that they're using.
Mouthwash. Mouthwash
Yeah.
and toothpaste
Yeah.
does that. But when it's really on the cheeks, it's usually mouthwash because they
Yeah.
puff out in their cheeks. There are a lot of strong mouthwashes out there. And even the newer mouthwashes that say they're alcohol free are not necessarily gentle.
Oh, yeah.
Mm.
Yeah, they have some other chemicals in them.
Mm.
But this was a cheap store brand mouthwash with this patient.
Mm.
A store that is no longer in business. If I told you the story, you'd say, "What? I never heard of that." But anyway, yeah, it was mouthwash. That one was mouthwash. But if you told me it was toothpaste, I'd be just as happy with that because some of the stronger toothpaste, particularly the strong flavoring agents in toothpaste that are very popular right now, cause sloughing. And you will see these at your dental hygiene appointments. Your
Okay.
patients come in because they brush their teeth really good and use their mouthwash before they come in, so they'll have good breath, and so you'll think that they always keep their teeth really clean. So we see a lot of these really superficial, sloughy kind of chemical burns from oral hygiene products on the day of a dental appointment because
Oh,
they
on the
clean up
day,
really good
yeah.
right before they come in.
Yeah.
Yep.
Okay.
So you'll see them. And what I usually tell patients when I see this kind of response, this kind of injury with an oral hygiene product is that they either need to switch to a milder brand of toothpaste or mouth rinse, or if it's mouth rinse, dilute it with water.
Oh,
Or
okay.
don't rinse quite so long because you are causing injury to the tissue.
Mm-hmm.
What is the gentlest line of oral hygiene products that we can recommend for our patients?
So you said alcohol-free isn't as gentle?
Well, some of them are not as gentle as you would expect.
Okay. And you're saying products, right?
Yeah,
Yeah.
so what line of products is the gentlest that we can recommend for our patients?
Sensodyne?
Yeah.
No, that's
No?
really good for sensitive teeth.
Oh.
It's not particularly chemically friendly to the soft tissue, though.
Mm.
It's not horrible,
Mm-hmm.
but it's actually not that gentle.
Okay.
Crest? No.
Something I know you've heard of.
Coconut? No, I'm thinking of natural now.
Yeah, the coconut oil is
Yeah.
actually, that's very soothing in the
Yeah.
mouth. Do they teach you about oil pulling?
I think we're
Oh, yeah.
doing a project
Oh, cool.
about that.
Yeah.
My group
Oh, I
is
want to. Are
actually-
you doing that?
yeah.
Oh, I want to see the results. I have patients who ask me about it.
Yeah.
I have a lot of patients who are kind of into the natural things. So,
So we're
Oh.
gonna do research on it. And
Good,
Yeah. So it's
good.
yeah. My friend was like, "Oh, this is really interesting," and I was like, "Okay, let's
Oh,
do it."
yeah, I want to see the research on
Sounds
that one.
good. Yeah.
Yeah.
So the gentlest line that we can recommend for our patients is the Biotene line. That one
Oh.
is very gentle.
Oh, okay.
People with
Biotene.
dry mouth have very delicate tissues and they do not tolerate strong chemicals.
Mm-hmm.
The mouth rinse is actually moisturizing and is very gentle, no alcohol, but it doesn't have the other nasty chemicals that some of the other ones have. And the toothpaste is pretty gentle. They've made some changes in the toothpaste, and the flavor is a little stronger than I'd like, and a little stronger than some of our patients like, but it's still a very gentle line.
Mm.
Some of the Toms of Maine products are very gentle too, but the toothpaste, you got to read the labels. Got to get the fluoride toothpaste. I don't care what the nature freaks, tree huggers say. You got to have your fluoride. I'm a dentist.
Yeah.
You got to have your fluoride.
Yeah.
All right,
Mouthwash.
that was our clove oil.
Mm.
And you'll never guess this one. This was a phenol burn when you used to be able to get phenol in the drugstore. So kid bites their tongue and parent goes out and gets phenol and applies it as a topical anesthetic and causes a worse injury than the kid had to begin with.
Oh.
One of the problems with phenol is it has to be chemically inactivated in order to stop burning. You can't just rinse it out. It works a little bit differently.
Okay.
So you have to have a lot of respect for things with phenol in them, and that's what's in Anbesol. So you just can't overdo it with those products because they will burn the tissue. So that was a
So it's
phenol burn.
Mm.
Yeah, you don't see just pure phenol anymore. You can't just go out and buy it at the drugstore like you used to be able to, but there are still products available that have phenol in them, and you do have to be careful with them.
Mm.
This one, patient complains of toothache. A lot of pain from a toothache.
Looks kind of like
Aspirin
an ulcer.
burn, I think. 'Cause
Is that a
it's-
typical burn with the
Oh,
white
wait.
sluffy?
For aspirin? No.
No, it's
'Cause
not.
that's like-
But you know what? That is what it was.
Oh, okay.
Oh.
So they just kept it right in the same spot. So it
Yeah.
ended up having a deeper injury that got an ulcer membrane and then the redness around it instead of the typical just little sluffy.
Yeah.
Okay.
So it ended up being an aspirin burn. So the history was very helpful on that one.
Yeah.
So sometimes our chemical burns do not present classically, and we have
Okay.
to think a little harder. I don't think I would use this one for quizzing and testing, but I do want you to be aware that sometimes they don't present classically.
Does it look like an ulcer at all?
Yeah, but the ulcer membrane is really thick, so it almost
Okay.
elevates the surface instead of being depression.
Okay.
But keep in mind, you know where this is. The tissue's very thin there. There's not much room to have a depression.
Oh, right.
That movable mucosa,
Mm-hmm.
right there at that mucogingival junction, the tissue's very, very thin at the anterior mandible.
Mm.
So the ulcer membrane kind of mounds up on top instead of creating a deep depression. There's no
I
room
see.
to have a deep depression in the tissue there. The tissue's just not thick enough.
Mm.
These are some more. I'm kind of tired of our chemical burns, so I'll just tell you what they were. This was a toothpaste one. This was Crest toothpaste.
Mm-hmm.
And so, particularly when they came out with the tartar control crust, stronger flavoring agents that to cover the tartar control chemical, and a lot of patients got burns from it. And some people are allergic to it. The allergies are usually red. The superficial white sluffy is the chemical burn.
Mm-hmm.
This patient was using hydrogen peroxide. I'm going to help my periodontal disease. Burn the living daylights out of the tongue, and look how red the cheeks are. Been using it daily for long enough to really get a nasty burn throughout the mouth. So I always tell my patients, do not put hydrogen peroxide in your mouth. It's just better for other things. What do you think of that one? Toothache. Yeah, but can you see where it's cracking and peeling, and some is sloughed already and some is not?
Yeah.
That's a really classic aspirin burn. That was a patient I saw when I was a resident. One of those weekend toothaches, shows up for urgent care appointment on a Monday morning. Classic aspirin burn story. All right, now we're going to look at allergies. You want to take a quick break? I need to get a drink of water and run to the restroom.
Okay, sounds good.
And I'm going to check my battery. Are we going to make it? We started out with 88. Yes, we're going to make it through. So. Now I have to get back to where I was. Can I go to?
Yeah. Is there a water fountain?
Right out in the hall. The best one in the whole building.
Yeah, it's like the highest grade we can get for this class
C.
is C. It's
Yeah.
like, are you
Damn.
serious?
I know. What?
No, I think this professor should be really cool.
Oh.
Yeah.
Oh, you mean the other
The
one?
other one.
Oh, yeah.
She's cool too.
Yeah. And I kind of like for that for the quiz. I didn't see that little ulcer in the back.
No, me too. On some of them, I put like the same answer. I was like, oh my gosh, why am I overthinking it? It's because
I
we're
got the same
nervous
answer.
right now.
Yeah.
We're nervous. Honestly, it's the first quiz and everything.
Yeah.
Don't worry.
Yeah. But yeah, I put a couple of the same answer.
And I was like, yeah. Don't worry, Brian. We'll push through this course.
Yeah.
And
We'll get this.
We'll do it.
Good thing Good thing we didn't have to take it in the spring.
Oh yeah. That would have been so bad.
Yeah.
It's better to just get it out of the way now. And then
Yeah. Because I heard like the seniors that took it they had less clinic time because of that.
Oh, you're so right.
Yeah, so like that kind of sucked for
Yeah.
them.
At least we'll be done with it this quarter. I'm just glad he agreed on doing it and teaching it
Oh,
for
yeah.
us.
Yeah, that was like last minute.
Yeah.
Oh my gosh.
I remember that. I guess he gave Miss Lee, because he taught Miss Lee's class.
Yeah, I remember.
Yeah,
I remember
and he
that,
gave to them the final exam.
Yeah.
So let's talk with him.
Yeah.
We gotta be cool with them and everything. Oh no.
Yeah.
We'll be fine, dude.
Yeah. Yeah. So.
It's okay. It's the three of us.
I think I don't know. It's just like sometimes it just gets like confusing, you know. Like.
That's how I feel too, because
Like
it's
this-
like they all look the same,
They're all
and
the
it's
same,
like
yeah.
the history is like.
Yeah, and it's like you have to go through your head and like,
Yeah.
think about like what it is. So
Mhm.
many things.
I feel you. I feel the same way.
Yeah.
So how many years have you been working?
Here?
Yeah.
I came back to teach from residency in summer of '87.
Oh, wow.
So over 30 years.
Wow.
I think
wow.
I'm on my 33rd time through general and systemic pathology with the dental students. So I've been here a long time.
Oh,
My
wow.
official appointment is longer than that because the dental school sponsored me through my grad program.
Mm-hmm.
When I was a senior dental student, one of our pathologists, oral pathologists, decided to go to another school and they needed a replacement, and they remembered that I really liked oral path. So they came to me and said, you know, are you interested in taking path and coming back and teaching? And it's like the job market was terrible for new grads. I was actually, as a Southern California local girl, looking at a practice in Nebraska to buy. That's how bad the job market was.
Oh, wow.
I was willing to look at Nebraska.
Yeah.
So I thought, wow, I have an opportunity to do something I really like and have a job waiting for me. So
Yeah.
I said, yeah, I'll do it.
Wow.
But the deadlines had passed for all the programs. And the USC program was still open.
Mm-hmm.
So the department chair here, Dr. Rick, called them up and asked, you know, have you filled your spot in your oral path program for this year? I know the deadline's passed, but we have somebody that's really interested. And the program director said, well, as it turns out, this is the year that we don't take a resident. We have funding for a resident 2 years out of every 3, so they have a skip year, you know.
Oh.
And this is the year we didn't take anybody, we didn't take applications because we don't have funding for a spot for this year. And so Loma Linda says, well, we have somebody we're really interested in sending, and if you don't have to pay this person, would you consider their application? And they said, well, we won't make any promises, but if we don't have to pay them, we will look at the application.
Oh, wow.
So that's what happened.
Yeah.
And I applied in April, late April. I interviewed the week before graduation,
Wow.
was accepted the week of graduation.
Wow.
So, and took my boards right after graduation. We had a Friday morning graduation. Cal boards started on Sunday. Right after boards were over, my family went on vacation. I came back and immediately started residency. It was like boom, boom, boom.
Wow.
But it was a miracle, and I really believe in God's leading
Yeah.
because the next year was the last resident they took. And the
Wow.
program closed, and I could
Wow.
not have competed with that applicant. The
Huh.
applicant the next year that was accepted was a student who had almost finished a PhD in pathology, only had to write up her thesis,
Wow.
done with the research, who went into dental school with the intention of taking oral path and being dual degree PhD oral path.
Huh.
And the program was dual sponsored by the medical school and the dental school. And the medical school department chair was so excited about that applicant that he accepted her without consulting with the program director, who was the dental person.
Wow.
And they had such a falling out over it
Wow.
that the medical center pulled the funding for the spot and it closed the program. So she
Oh.
and I were the last 2 residents, and I could not have competed with her PhD in pathology. So if
Wow.
God hadn't opened the door for me to go then, I probably wouldn't have gone at all. So it's really a miracle how I ended up
Wow.
going. It was a really good program, and I have been back here. So when the school sponsors you through a program, at least at that time, they paid me an instructor salary, which is the lowest of the lowest. I think GPRs pay more than I got paid. But I got paid as an instructor for the 3 years of my residency, and I had to pay back 5 years' time. I had to promise to stay and teach 5 years, and now I've been here for over 30, so I think they got a good return on their investment.
Oh. Wow.
Wow, that's a
pretty
lot
cool.
of years.
So to get a PhD in pathology, is that
There aren't a lot of people who
Oh.
have PhDs in pathology
Oh.
who are in oral path.
okay? Oh, so that previous applicant went through dental school?
No,
Oh.
she did the PhD in pathology
Oh.
as a non-medical basic science
Oh.
person,
Okay.
and then decided wanted to go healthcare to apply it, and applied to dental school, went through dental school with the intent of specializing in oral path,
Oh wow.
which is a very unusual thing.
Yeah.
A
Yeah.
very, very
I
unusual
mean, going
thing.
straight Do you
Yeah.
bypass all the dental school and then go straight to...
Nope, you
Oh,
have to
yeah.
go
Oh.
through dental. You have to become
Okay.
a dentist first.
Right.
Wow.
She had to get licensed and the
Okay.
whole thing,
Yeah.
and then apply.
Oh.
But she's very bright. She's now retired. She was older than me actually, because it took her a while with all the PhD and stuff.
Yeah.
And she's now retired, and I'm still working. But she's an awesome pathologist, just
Oh.
outstanding.
Where is she now? Not at this school?
No, she was from the state of Washington.
Mm-hmm.
And her first job out, she was at Tufts. I think she was at Tufts.
Oh, Tufts. Okay.
Is that in Philadelphia? Is Tufts
Sounds like
in
an
It's
East
in
Coast
the East
school.
Coast school,
Yeah.
yeah.
She was in Philadelphia, but I think she was at Tufts. And then she went to New Jersey, and she taught it in New Jersey for years and years and years.
Oh, wow.
They loved her. They did not want her to retire, but she retired.
Okay.
And her husband, she married a man from New York, so she stayed on the East Coast when she retired,
Oh.
because that's where he was
She's
from.
from, yeah.
Oh, okay.
But
Wow.
we were the last two. And
they-
now there
yeah.
aren't any programs on the West Coast at all in Orland Path. You have
Oh.
to go to at least the Midwest.
Oh.
So things
Oh.
have changed. It's so sad, but it was a really good program we were in. It was tragic that it closed.
Mhm.
Yes. All right.
Yeah.
So we only have a few long Friday afternoons because the time changes soon and we can only go 2 hours. So
Mm.
gratefully. We are moving into our allergies and immune-mediated diseases. These present clinically very similarly to our diseases that are related to injuries. It's getting low. And that is because they have an inflammation component that's immune-mediated that produces a redness. So often a lot of redness and sometimes even surface ulceration. But the histories are different in that very often the immune-mediated lesions are of longer duration. They didn't just happen yesterday or the day before. There are some types of immune-mediated conditions, though, that can develop lesions very quickly. And that's the one we're starting with, our type 1 hypersensitivities. Because those are the ones where you have antibodies to something, and as soon as you get exposed to whatever that antigen is, the reaction happens very quickly. That's why type 1 hypersensitivities are called immediate type hypersensitivities, because it is such a fast reaction. The two types of diseases that we see in the mouth that are type 1 hypersensitivities are angioedema, which is not very common, and our stomatitis medicamentosa, which would be a type 1 hypersensitivity reaction to a medication or drug, or sometimes a chemical that's not prescribed, like an OTC type of chemical as well, but you're kind of using it in a therapeutic way. So this is a patient who was given penicillin for a respiratory infection and developed a skin rash, and you can see the skin rash, kind of a welty, hivey kind of rash on his forehead, but it's all over his trunk as well. And then the next day developed mouth lesions as well. So the overall diagnosis in this patient was type 1 hypersensitivity, was penicillin. This was a penicillin reaction. A lot of people are allergic to penicillin. But we have a specific term that we use when we have oral lesions associated with a type 1 hypersensitivity to a medication. So what's that term?
Stomatitis
Medicamentosa. Sometimes we see more specific patterns. There are some other diagnostic patterns that are a little more specific. So we tend to use the term stomatitis medicamentosa for the more generalized, just ulceration and redness in the mouth that doesn't have any specific pattern that looks like this disease or that disease. So this is the generic one. Okay? But those can come up pretty quickly. Within hours, the rash, the ulceration, and oral lesions usually take a few more hours than the skin lesions.
And this is due because of penicillin, you said?
This was
Yeah.
a reaction to penicillin. A lot of people are allergic to penicillin.
Yeah, because I've never heard of a reaction happening like that, like a rash looking thing.
Like this on the skin? Oh, yeah.
Yeah, it's really common, huh?
Yep. That's the traditional drug allergy
Allergy,
reaction is a
okay.
rash. But penicillin, the type 1 hypersensitivities tend to be the Hy-Vee soft, welty like rashes. So that's a pretty good one. Now these are a little bit different. The patient on the left came in for a dental appointment with a normal lip and within a few hours had a swollen lip. That's the only thing that's swollen was just the lip. It's soft swelling. It's not tender. It's just swollen.
Angio.
That fits with our angioedema. And this one ended up being a type 1 hypersensitivity reaction to local anesthetic. And we have since learned it was the preservative that was the problem in those local anesthetics some people were allergic to. But when it's that specific pattern of just swelling, particularly on the lip and face, then angioedema is a better diagnosis than stomatitis medicamentosa.
Okay.
Does that make sense?
Yeah.
Okay,
Yeah.
good. This patient has a little localized area of swelling on the lip. It's not the whole lip, not diffuse lip. And this appeared over a period of hours after starting a medication that contained iodine.
Stomatitis.
Medicamentosa.
Stomatitis medicamentosa.
And that's because of medication. That's
Because
how,
it's medication and it's not like a specific pattern like angioedema. So this is what a localized anaphylaxis looks like. In our patient, if we go backwards, our patient with penicillin, that Hy-Vee soft kind of rash, if you see that in the mouth, it looks like that. That's the nearest equivalent. But we actually don't see that in the mouth very often. We more often get redness and ulcers, but this one's kind of a localized anaphylaxis. So we would call that stomatitis medicamentosa. Sometimes patients who usually has problems with iodine, people who are allergic to shellfish. It's actually the iodine in shellfish that often causes the allergy, people who have problems with shrimp and lobster. And they may get a medication and not know it has iodine in it and not know that they can have the same kind of reaction as they do to shellfish. Oh, this one has a long story. I think we went over it in class. This was the patient who had multiple impressions taken for a new denture using a ZOE material, zinc oxide eugenol. And when it wasn't a good impression, they cleaned everything up with orange oil and took a new one. And over a period of hours and a couple of days, she got this area of ulceration and redness, and it would really, really hurt. But she also got a skin rash and a rash on her face and some swelling around her eyes. So, was this a local reaction, chemical burn, or was this an allergic reaction?
Allergic.
It fits better with an allergic reaction because of the involvement with the hands and the face. But that one's those, you have to really think hard about that one. So that fits best with a stomatitis medicamentosa. And on that one, it's really hard to know what it was a reaction to because she could have absorbed the orange oil, and some people are allergic to that. Could have absorbed the eugenol, which some people are allergic to. So probably the eugenol. A lot of people are allergic to eugenol. So what else do we use eugenol for in dentistry? Do you know?
Is it? No, I don't.
Maybe.
We use it in temporary cements.
Okay.
One of our favorite temporary cements is ZOE, zinc oxide eugenol, but enough people are allergic to it that a lot of practices use an alternate called nogenol because it has no eugenol in it, but still works as a nice temporary cement. So eugenol seems to be something that people get allergic to fairly easily. Aha! These are more angioedema cases. This was our young man with the angioedema that Dr. Thompson took out on a hike in the mountains. And the sunlight triggers it, so it's not always an antigen that triggers it. It can be a physical stimulus that triggers histamine release. This was a local anesthetic, so that was an IgE-mediated type 1 hypersensitivity.
Did he know that?
He know it?
Yeah. Did he know that?
Oh yeah,
Okay,
he
'cause
told
I was
Dr.
like-
Thompson, this happens to me every time I get too much sun.
Oh, okay.
And that's
okay.
why I wear the hats, but the hat didn't have a big enough brim on it. It was not a big enough hat that day.
Yeah.
So, yeah. Yep, his picture is down in the hall with the dental graduates, but you would never recognize him
Mhm.
as the
Yeah.
same person,
Oh.
you know, between this picture and that picture.
Yeah.
You'd never recognize him. So, we already talked about histamine release, IgE-mediated type 1 hypersensitivity being the most common cause of angioedema. It can be the direct physical stimulus, heat, cold, sun, stress, exercise even. I have met people who it was a cold reaction. The one we just looked at was sun exposure, but there can be other types of physical stimuli that trigger it. The only other really important trigger that I think you should know about is the ACE inhibitor drugs that allow overproduction of bradykinin, which triggers complement that does the same thing, increases vascular permeability and produces rapid soft swelling of the tissues and exudation. There are also those rare patients who have an inherited deficiency of C1 inhibitor, complement C1 inhibitor. So that allows overproduction of complement producing angioedema. But the ACE inhibitors, and you've taken pharmacology now, you know about ACE inhibitors. That's a side effect of ACE inhibitor drugs that physicians are very well aware of. And that's one of the things we see angioedema more from that now than we do most of the other causes. So it's kind of the first thing to check is the health history and are they taking an ACE inhibitor drug. So that activate that one is bradykinin related, but the C1 inhibitor is the problem right here in the complement cascade. All right, type 4 hypersensitivity is another category of immune-mediated diseases, and these can be cell-mediated allergic reactions to something that's absorbed through the oral mucosa. That would be our contact stomatitis, which is typically red. Sometimes our contact stomatitis has a white lacy pattern like lichen planus, so we call it lichenoid contact stomatitis. We can also have other rare diseases in the mouth that have type 4 hypersensitivity disease mechanisms. The only other one we talked about was, I think, our polyangiitis, our granulomatosis with polyangiitis, formerly called Wegener granulomatosis. So,
Lichenoid.
that would be our lichenoid one.
Lichenoid contact.
And the lichenoid contact stomatitis is often a reaction to a metal in the mouth. That is one of the more common types of antigens that produces that reaction. Although I wouldn't call that a perfect lacy pattern, it being that white and red mixed where we contact the lesion is still a pretty good pattern for a lichenoid contact reaction.
type 4,
And I actually
yeah.
see these in patients
You do?
sometimes. I do. They are uncommon, but not at all unheard of. So you could see this in practice. Would you call this one a lichenoid reaction?
No.
No, it's just red.
Contact stomatitis.
So of the things we've talked about, it fits with contact stomatitis, but lots of things can produce red.
Yeah. Oh, that's
So
true.
when would red changes in the mouth make you think it's contact stomatitis?
When something is taken in, like maybe like
When there's exposure to something that could be a sensitizer,
yeah.
when there's tenderness with it, when it's been there more than a day or two, because type 4 reactions take longer to develop, and usually patients don't figure out what they're related to, and it may have been going on for weeks
Yeah.
because they don't figure it out and don't know what to eliminate to get rid of it. The classic presentation of a contact stomatitis in the mouth is redness, often with a little bit of granularity to the surface. So this one is a really nice classic one. This was Dr. Thompson's patient.
Oh.
Yes, he should be giving this lecture. And this one ended up being a reaction to Crest tartar control formula when they first came out with it, and it's that cinnamon flavoring that they
yeah.
use so much of. At that time, when this patient was seen, nobody knew what it was that was
wow.
causing it. But everybody started seeing reactions in
Yeah.
patients that were using the new tartar control crest. Some of them were the burns, the white sluffy, and others were just the red like this that were the type 4 hypersensitivity, the contact stomatitis. And that resolved really, really nicely after she stopped using the toothpaste.
Mm.
The patient on the left wears a denture, has had dentures for decades, has recently gotten a new denture, and ever since she got the new denture, it's tender underneath it. And when you examine her, there's redness and some other little modelly changes, and it just follows perfectly the outline where the denture touches the tissue.
Contact stomatitis?
Could that be contact stomatitis? What else would you consider? Anything else that we see under a denture? I'm sure
Yes.
you learned something else that could be seen associated with a denture.
Mm-hmm.
What?
We did mention the epilus fissuratum, but
That would be under the flange and not
Yeah.
everywhere. And
Okay.
that is a proliferative change. It has a little mass there.
Yeah.
Okay.
And this is all flat. It's just red and it's tender.
Mm.
Feels irritated and sore. What else would you think about?
Something not from this lecture, right? Yeah.
Yes,
that can cause it.
something
Yeah,
not
yeah.
from this lecture,
That's why. So I'm trying to think. So he said epilus fissuratum,
which
but
doesn't fit with what we
the
see.
gran-
But what could produce redness under a denture and be sore?
so I know maybe like some kind of irritation due to the denture.
And this is like the palate, so
I'm thinking physical irritation?
Yeah, that's what.
That doesn't usually be, that's not usually everywhere. It's usually
Oh.
just one place that rubs,
Okay.
and you'll get like an ulcer in just one spot,
Uh huh.
maybe more than one spot, but not everywhere fairly uniformly.
Okay.
Anything else? I'm surprised you haven't
Uh,
zoomed in on it. My dental students would.
zoom
Would be
in.
the first thing they think of.
I can't think of the name right now.
yeah.
A lot of people, my dental students and dentists would think first and foremost of candidiasis under a denture.
Okay.
Okay?
Or, okay.
But usually candidiasis under a denture is more severe over the vault of the palate and not perfectly the whole outline of everywhere the denture touches.
Okay.
So the fact that this is everywhere the denture touches and just perfectly follows the outline of the denture, even up in the vestibules it did,
Mm-hmm.
suggests that it's not candidiasis and might be something else. This was a patient I saw. We actually treated for candidiasis just to make sure. No difference.
Mm-hmm.
We tried some other things, no difference. We ended up biopsying her. And it was intense chronic inflammation with lots of plasma cells. It was an allergic reaction. So she had gotten a new denture that had slightly different acrylic, and she was allergic to it. So we had quite a hard time treating her because there aren't really good alternatives to acrylic for dentures.
Mm.
So we had one of our prosthodontists make her a denture out of light cured acrylic, and she tolerated that better
Like cured it.
because it was a little bit different chemical composition, and she did better with it. She still had to use some steroid, a little bit of topical steroid to kind of keep it under control, but she was able to at least use her denture to eat and things like that.
Mm.
But
I see.
allergies to dentures are very rare, very rare. Patient on the right, it's red and white. We've seen things today that are red and white. This has been present for about a month. It's very tender. Similar changes on the other side, but not quite as severe. Involves cheek and tongue. And it's white with a red background. So, is it
Mhm.
is it
Um,
allergy or immune mediated redness, or is this response to injury? Is it a chemical burn? Everything we're talking about today could apply to this patient. How would you sort through it to make up your mind?
Is there pain on the tooth?
Is there pain on the tooth? No teeth with pain.
Okay, so contact stomatitis. It has to be like.
Fits better
Yeah.
with that than an aspirin burn.
Yeah.
Mhm.
But do patients usually have aspirin burns on both sides fairly symmetric? No.
No.
So there are other kinds of chemicals. So this still could be a chemical burn.
Okay. So it'd probably be a mouthwash
So,
type
well,
of burn because it's both.
what could you do to decide that would help you decide if this is a chemical burn or not? Besides just looking at it,
Irritation. No, either way, both of them.
can have similar
Yeah.
symptoms.
Yeah.
That's why we
Mhm.
put these two topics together, because there's a lot of overlap in both their clinical presentation and their signs and symptoms, and sometimes even the durations.
Wouldn't this be immune mediated?
Why?
Because you had mentioned it happened over a longer.
It's been there
period
for
of time.
4 weeks.
4 weeks.
But we can always have repeated injuries.
Oh, yeah.
So, and it's
Okay.
still fairly short duration. What
Okay.
is a typical feature of a chemical burn? If you could have one word that describes a chemical burn clinically, what would it be? If you only got one word,
Sloughing.
sloughing. Good
Mm.
word.
Mm-hmm.
So you want to know if this sloughs. That would be the most useful thing to help you distinguish between a chemical burn and a contact stomatitis.
Mm.
Contact stomatitis is inflammatory, it's immune mediated. Really severe cases might have ulceration, but it does not slough.
Oh, okay.
It turns white without sloughing.
Mm.
It doesn't really have necrosis as much as inflammation and stuff. So this one did not slough. You could wipe it, no sloughing, no spontaneous sloughing. You can
Okay.
stretch it, and that's tender, but it doesn't crack and peel. So
Okay.
is it a chemical burn?
No.
No. So then you're working with probably a contact stomatitis.
Mhm.
Okay. So now that you've decided this might be a contact stomatitis and the patient has no clue what it is, what kinds of things would you think about as possible causes of a type 4 hypersensitivity that would produce changes on the lateral tongue and cheek?
Lateral.
Okay.
Remember that contact stomatitis occurs in a region that directly contacts the antigen.
Mm-hmm.
Right.
This is only on the cheeks and the lateral borders of the tongue.
Okay.
So what do those two tissues have in common that could be a source of antigen?
So like toothpaste, right? Like something
Toothpaste?
that.
We
Yeah.
usually see those changes on the gingiva because you're
Just the
brushing it into
gingiva?
the gingiva.
Okay.
This wasn't really gingiva, it was cheeks and tongue.
Oh, whitening? No.
No.
Mouthwash.
What do your cheeks and your tongue both come into contact with at the same time?
Teeth. Yeah, like
Teeth?
chewing.
Are we allergic to our own teeth?
No.
What do we put between our teeth?
Gum.
Gum? Food?
Uh-huh.
Something that's being chewed on.
Yeah.
Okay.
Mhm. So it's gum. Synonym. Flavored
Yep,
gum.
yep.
Yeah.
Okay.
But you would also think about foods. We don't get contact hypersensitivities to food very often, more likely to have a type 1 hypersensitivity. So I would go to the gums and candies.
Okay.
Gums and candies.
Mm-hmm.
And this one did end up being the cinnamon chewing gum.
Mm-hmm.
But
So-
isn't that type 4? Contact
Yes.
stomatitis. Okay,
Yep.
so it takes time for
It takes longer
okay.
to develop.
Okay.
It takes longer to resolve too after you stop chewing the gum
Okay.
or whatever. Okay. What do you see?
I see metal and a reaction to that metal.
And how would you describe that lesion?
Lynch node.
But yeah.
Wait.
You're as bad as our receptionist. In our oral medicine clinic where we saw these patients, we used to have a receptionist, and she called it lichen planus. She would
Oh.
say lichen planus on the phone with patients, and every time I'd hear it, I'd just cringe. So it's lichen, like the lichen that grows on trees, and it's lichenoid or lichen planus.
Okay.
Yes, lichen.
I need a,
Yeah. Okay.
lichen planus.
So, is this lichen planus, or is it a lichenoid contact
Lichenoid.
stomatitis?
Lichenoid,
Contact.
The fact that it's right on tissue that contacts metal restoration better supports a lichenoid contact stomatitis than an idiopathic lichen planus.
Okay.
Idiopathic lichen planus we'd expect all along the cheeks, irrespective of where restorations are, that kind of thing. All right. What about this patient? What color are those lesions?
Looks like a red lesion.
Red lesions. No white, no lichenoid, anything, just red. And she has newly placed brackets for orthodontic treatment. So what's the first thing you would think of for a diagnosis for those red spots?
Well, actually, because there's metal on the braces.
There's metal on the braces. But what's the first thing you would think of?
Contact stomatitis?
No.
Or like the physical.
The physical irritation from the
Irritation.
brackets.
Oh, yeah.
Yeah.
So you would think maybe a traumatic mucositis, and that's what the orthodontist thought, covered the brackets with wax and did not help. And the red things got bigger and more severe, and that's when they started thinking, this isn't traumatic. She was actually biopsied, and it ended up being a contact stomatitis. Ended up being a type 4 hypersensitivity to the nickel in the brackets. So sometimes you have to do some real sleuthing. This one's a hard one. What about this one?
So a lot of like swelling and
Swelling? How would you describe it besides just swollen? Definitely has some swelling and thickness to it though.
a lot of red,
Very red.
very red. Yeah.
What else?
I remember you describing like strawberry.
It's bumpy.
Bumpy.
Bumpy
yeah.
and grainy,
Yes.
but it's bumpier and grainier than that contact stomatitis we saw early. That one didn't have this thickness to it and bulk to it. It was just kind of delicate grainy. Is this delicate grainy?
No.
No. This is more of that strawberry raspberry looking grainy.
Yeah.
So that's when we have the suspicion that we might be working with granulomatosis with polyangiitis. This isn't something that I'm likely to put on a test for you, but because you're hygienists and you look at gingiva, I just want to remind you sometimes the things we see on gingiva are very serious diseases. And if you saw something like that, you would know that is way out of the ordinary and needs prompt attention.
Yeah.
And you would have the dentist get on that right away. That needs to go for a biopsy. That is not any ordinary allergic reaction or something like that. And this is a disease that needs treatment started with sooner rather than later, because it's a potentially lethal disease. In fact, I just lectured with the dental students on this morning, and it has an 80% mortality rate if treatment is not started within a year of onset.
Wow.
Yep.
Oh, yeah, that's
80%
pretty-
mortality. That's
that is
not
pretty bad.
good. It's a very serious disease. This is a patient with early disease. Now, she came in to see you to get her teeth cleaned and said, I have these gingival changes and they're new, and my lip is split and it won't heal, and I'm getting these little grooves and slits in my tongue that I never had before. Would you be suspicious of granulomatosis with polyangiitis?
No.
No. You would know it's not normal, but the first thing you would do is work with local factors.
Yeah.
And when there weren't any changes there, that's when you send these patients to a specialist. But this one, when it's already over the top,
Yeah, for sure.
you should recognize what that might be, because there's nothing else that does that.
Yeah.
Okay?
Yeah.
With the grooves in the tongue, could
Yeah.
that be due because of a piercing in the
Yeah,
tongue?
but there would be a hole.
Yeah.
There's
okay.
no hole there.
Okay.
And she
And
had
it
some
looks
little
like-
slit-like grooves on the cheeks as well.
Okay.
So her tissue was just changing. It was just weird, but it started out really subtle. So she actually got diagnosed at this stage because nothing changed with changes in local factor, and a biopsy was done, and there was granulomatous inflammation, and she got sent to a physician for an extensive workup, and they found that it was granulomatosis with polyangiitis. But this one's pretty advanced before the patient got diagnosed. We don't want to ever see them get this advanced. That's pretty scary. I have seen a patient in the last, less than 5 years, came in. She had had symptoms for more than 6 months when she saw me, but it was this kind of thing just in the back, in the upper left molar area. And it wasn't all over the place. It was just localized. But she had other symptoms like the nasal stuffiness. And they kept treating her for sinusitis, and it didn't make any difference. And she had gotten sick enough over those 6 months that she was on medical leave. She couldn't go to work. So this is a disease that makes patients pretty sick. Yeah. But, nobody she saw put all the pieces together to realize that this is what it might be. So it was kind of interesting with her.
Is there something that would trigger
Trigger this?
Yeah.
They don't know what triggers it.
Oh, okay.
A lot of the immune-mediated vasculitis syndromes, we don't know what triggers them.
Okay.
Some of them we do, like Kawasaki disease is triggered by ordinary childhood viruses. It's seen in kids. This one, we don't know what triggers it. Not at all. So it's kind of sad. Then we get to the biggie. We've seen some immune-mediated things that are somewhat common, the contact stomatitis types of things, really, really rare, which is the granulomatosis with polyangiitis. We want to move on to the thing that we see in the mouth the most, hands down, that's immune-mediated, and that's our recurrent aphthous stomatitis. I see patients in special care dentistry down on the first floor for my private practice day. In October, I will have been there 25 years.
Oh.
I have my anniversary coming up.
Wow.
We only have one dentist who's been there longer than me now. But anyway, I love seeing patients there. I had a patient in on Tuesday of this week. Mom brought him in for an emergency appointment because it hurt where we had where I had placed a space maintainer about a month ago. And it just ended up being an aphthous ulcer in the region.
Oh.
But actually next to where the first molar hasn't erupted yet. Not by the space maintainer. So, and kid had not ever had a canker sore before. But as soon as I told Mom, oh, it's a canker sore, it's like, oh, the lights go on, and he hadn't had one before. It was a kid who hadn't had one before. So, but these are really common, and patients mostly know what they are, and they don't often seek treatment, but there are, because they may just have infrequent recurrences of them. But there are some forms that always require treatment. And anytime we have a patient who has history of aphthous ulcers, it's nice to know how frequently they get them, if they know how to manage their triggers, and if they're getting them often enough that we should offer professional treatment. I think that's a practice builder. So the three types are aphthous minor stomatitis, the most common form, aphthous major stomatitis, which is less common but always requires professional treatment because it's really, really miserable and severe, and herpetiform aphthous stomatitis, which is the least common but also usually requires professional treatment because they have so many ulcers at once. It's very, very painful. And over-the-counters aren't going to manage it. So, what makes it an aphthous ulcer? What do we look for that tells us the lesion is an aphthous ulcer? How did I know that the lesion in the kid I saw on Tuesday was an aphthous ulcer?
Red halo around.
Yeah.
The red halo, an ulcer, a small shallow ulcer that's nice and round or oval with that big red halo, really prominent halo. And the more prominent it is, usually the fresher the ulcer. As the days go by and it starts to heal, the redness fades. So the kid that I saw, it had only been there for a day, so it had a beautiful halo.
Yeah.
There was really not any doubt in the diagnosis.
Yeah.
And it was on the alveolar movable mucosa. So location is important as well as the physical appearance. Shallow tan ulcer, with that beautiful red halo, and they hurt way bigger than they are. That's really part of it too. They really hurt a lot. They are immune mediated. It is production of immune mediators that directly stimulate apoptosis and destruction of the oral epithelium. They take less than 24 hours to fully develop. They come on pretty quickly. I get these myself very rarely, fortunately, very rarely. In fact, when I get one, I have to think, what is this? It's like, what is it? Anyway, but I can get one from the first sign of prodrome to when you can see an ulcer 6 hours.
Oh.
They can develop pretty fast.
Yeah.
Pretty fast. And patients who get them often will tell you they come on pretty quickly. They develop pretty quickly. Most patients have a typical trigger. Definitely most common trigger is just plain old ordinary stress. But local trauma, chemical trauma, foods, lots of different things can be triggers, and it's really helpful for a patient to figure out what their trigger is so they can avoid it as much as possible. That is huge in the management of aphthous stomatitis. Sometimes we can't get rid of those triggers, but do the best we can. Before I leave that, what is a look-alike lesion for aphthous ulcers? What may look like aphthous but isn't?
A herpes.
A herpes. So how do we tell them apart?
Just asking questions.
Asking questions?
Location.
Location.
Yeah,
That's the most important thing. The herpes lesions start with a blister, a little vesicle. Sometimes patients are not aware of the vesicle, and you see them after the vesicle is ruptured, so they're going to be a little ulcer with a red halo.
Yeah.
They're often a cluster of them instead of just one or two, a little bit more. But the location on movable mucosa, never. They're always, the herpes lesions are always mucosa bound to bone when in the mouth. The only exception to that is a severely immunosuppressed patient who is probably not going to be in your dental office. They can get them anywhere in the mouth.
Oh, they can get
Aphthous ulcers even
anywhere.
on mucosa bound to bone because they are so immunosuppressed. They get weird things. But our typical healthy patients that are the ones who usually get this disease, they get them just on movable mucosa. So aphthous ulcers, movable mucosa, ulcers from recurrent intraoral herpes, simplex, mucosa bound to bone. So location is really, really important. But the time period that they develop, the symptoms, the prodromal symptoms, they're indistinguishable so much. So you do have to go by where they are. So they're recurring, they're self-limited ulcers. How long do aphthous ulcers usually last?
A week, right?
Depends on the type. Depends on the type. The common simple form, the minor form, is usually less than a week.
Okay.
Sometimes occasionally up to 2 weeks, but usually less than a week. The ones that last the longest are the major type, and they can last up to 6 weeks, commonly last 4 weeks. So duration really depends on the type, but they are self-limited. They do eventually go away on their own. If patients are getting lots of them, we can give medications that help them heal faster, and that's nice. Prodromal symptoms: burning, tingling, itching, right at the site where the ulcer is going to appear. And we already talked about their appearance, what they look like. So there's another one. So minor, usually solitary or 2 or 3. This one's actually 2, 1, 2. Last about 7 days, heal without scarring. And if we have frequent recurrences, may require professional therapy, but many patients are like me. They only have these once in a blue moon, and over-the-counter therapy is plenty fine. Just some pain management, and they go away on their own. So how often do they need to have recurrences before we want to offer them treatment? Specific prescription therapy.
If if it happens several times, right?
More than three times a year.
Yeah.
If it's more than 3 times a year, then that's a good time to start offering therapy.
Okay.
The major type is the one that is more severe, fortunately less common. So they get more ulcers. Instead of just 1 or 2 or 3, they may have 5 or 6 at a time, but not usually the whole mouth covered with ulcers. They usually have new ulcers appearing before the old ones have completely healed. So when you look in their mouth, their 5 or 6 ulcers can be in different stages. They can have new ones with a really broad halo and others that are older and shrinking and the halo's already gone. So, and they'll tell you, oh, this one I've had for a while. It's finally going away. This one just appeared 2 days ago, kind of a thing.
Okay.
They know exactly the story on every ulcer because they suffer so much from them. But they're very, very painful. They're larger ulcers. They're deeper ulcers. They do take longer to heal. But typically patients are in this just constant cycle of ulcers. In aphthous minor, it's usually discrete episodes separated by periods of totally wonderful, healthy mouth. But in aphthous major, it just never seems to completely go away, and they have this constant cycle of ulcers. So these are old ones, and this is an old one, but she had some bigger ones in the back. This is a fresh one with a red halo on soft palate. This is a little bit older one. This is a little bit older one.
You said that one's on the palate?
Soft palate.
Soft palate.
So this is the junction between hard and soft palate. We wouldn't see these on hard palate. We can see it right next to it on soft palate. This is a scar from another one that was previously on the soft palate. So these can heal with scarring because they're deeper. Yeah, they're horrible. And this is what she looked like after treatment. And she hadn't even been on treatment but just a couple of weeks, or it can take up to a month to break the cycle of ulcers. But topical steroids is what we use, and the dentist or physician has to prescribe those. Physicians are terrible at treating this. They have no clue how to treat it. So it's really much better to be treated by the dentist. Yeah. And I like the rinse because they can get it all over the place, everywhere in the mouth, to kind of stabilize it and stop the cycle of ulcers. So the herpetiform type of aphthous stomatitis is the one with the smallest ulcers, but the most ulcers at one time. So the size of the halo is way bigger than the ulcer. So they can be up to a couple of millimeters, not usually more than that, and often the little teeny tiny punctate ones like this. They can last a short time, like up to 7 days, or they can go a little bit over 7 days. The bigger ones might go a little bit over 7 days. But they often frequently recur, but typically are not in the constant cycle of ulcers the way aphthous major is. They do get some disease-free time between recurrences, although some patients it may not be very long. It may just be a few weeks before they have the next recurrence. So they usually do require professional treatment, and because they're all over, it really hurts. But again, it's all over, movable mucosa only. This is a different patient, not quite as many ulcers, but it's still lots and lots of them. Some of them teeny tiny, some of them a little bit bigger. Under the tongue, soft palate, buccal mucosa. There are lots of different places, all movable mucosa. And big halos. All right. Which is the aphthous ulcer? Because?
Of the movable. Oh, wait, is that one? No.
They're both
actually.
movable.
Okay, never mind.
It looks like this one is deeper, like.
That's a little deeper, and
The halo.
the red halo.
Yeah.
The red halo. So this was a patient with a toothache, got temporary filling, but was using, actually this one was camphophenique, which you could get over the counter that topically numbs, and was putting camphophenique next to the tooth that hurt. So that ended up being a chemical burn, and with a little bit of superficial necrosis, and this one is an ulcer with a red halo. That's the aphthous ulcer. So I thought I'd try some lookalikes and see how you do. All right, we talked about aphthous stomatitis treatment. If it's more than 3 episodes a year, for any pattern, it's time for treatment. always need treatment for aphthous major, usually need treatment for herpetiform aphthous stomatitis. The minor one usually only if it's more than 3 episodes for a year. And you can always identify and avoid triggers and do palliative care in addition to doing steroids to combat the inflammation that really causes it.
So you said for the herpetiform one, you always need treatment?
Usually, almost always. I would say always is better than risking missing, letting a patient suffer. Yeah.
And the one that's more than 3 episodes per year, is that for the major? Or?
Major is always more than 3 episodes per year. The nature of the disease is more than that. So minor would be more than 3 episodes a year. And minor, because it's more localized lesions, we use usually a gel that they just spot apply. The best time to start treatment for any of these is with the prodrome. If you start your topical steroid in the prodromal stage, sometimes the ulcer won't develop at all. It stops the inflammatory process sufficiently to allow the prodrome to disappear and not get ulcers at all. And that's kind of one of our goals of treatment. So patients who have the minor form, that's frequent enough to require treatment, they need to keep their medication handy all the time. So if they feel one coming on, they can start treatment immediately with the topical steroid directly applied to the place that's got the tingling burning, and apply it 3 or 4 times a day, sometimes 5 times a day, don't go more than that. And it can abort within 24, 48 hours. Completely abort. So it's amazing. But you have to start it right away. If you don't start it soon enough, you will get an ulcer, but it won't be as big and it will heal faster. So the topical steroids can cut the healing time in half.
Oh, okay. That's good.
At least knock off 2 days and sometimes in half.
So topical steroids?
Topical steroids. I like the fluocinolone gel for the minor type, and I like the dexamethasone elixir for the major or herpetiform types that have lesions in multiple places. I'm scratching. Do I have another? But I've been getting mosquito bites.
Yeah, I was studying outside one time.
I have a bad one here. This one's almost gone, but it was like this big and really, really red. And then I have one on the knee, and then I got one here. These are all this week. And it's like, man, where are these mosquitoes coming from? I haven't even seen them, but boy, they like me.
Wow. Yeah.
So, all right, what else do we have? There they are, the ones I like. Fluocinolone gel I really like. Triamcinolone was a little weaker. I wouldn't use that on anybody except the aphthous minor patients, but it works really well for aphthous minor. It's a good one. Topical anesthetics are for pain control. You do have to be careful that you use something for pain control that will not cause a chemical burn and that you give patients good instructions. But Ambisol, chloroseptic spray, they can dab it on with a cotton swab instead of spraying their whole mouth with it. Just put it right where you need it, but not too frequently, not too many times a day, or it can burn the tissue. Yep. And then they should be good. Coating agents. Most general dentists don't want to fool with the coating agents because they see patients who don't have lesions bad enough. But specialists who see the really bad patients, the coating agents can help a lot. So they seal the surface of the ulcer so it doesn't hurt as much. It really does help. So you can mix Benadryl with kaopectate or mix Benadryl with Maalox, and they rinse and spit, and it really helps it feel better. Physicians are on to this, and they put it in their Miracle mouthwash. So physicians who aren't very good at diagnosing oral diseases prescribe Miracle mouthwash, which has some nystatin just in case it's fungal in it. It has some usually dexamethasone elixir in it just in case it's chronic inflammatory condition, and they'll put some Benadryl in it and sometimes some kaopectate or Maalox, and sometimes they'll put an antibiotic in it too.
Oh, wow.
They just throw a whole, it's kind of the buckshot approach, something in this is going to help. I just don't know which one it is. if you know what you're doing, you don't need to use Miracle mouthwash. Just prescribe the one that they need.
Yeah.
So that works really well.
Oh.
So, was that a good review?
Yes.
Yeah.
Will you get more out of your study time now that we
Yeah.
reviewed it?
Yes.
Good,
yes.
good.
Yeah.
So you meet next week with Dr. Thompson. We are
Okay.
planning to meet in that little room down on the first floor, right across the hall from the hygiene classroom. And the office is 1199. And
Mhm.
if they don't have the monitor set up in time, we'll find a different room.
Mhm.
But you'll be meeting 8 o'clock on Thursday with Dr. Thompson.
Mhm.
I am not in the building on Thursday mornings,
Mhm.
so if anything goes wrong, he will be looking to the hygiene department to help him out.
Ah. Okay.
So Barbara, your secretary, or any of your hygiene faculty, that's who he's gonna turn to if he has any technical difficulties, because I won't be in the building to help him.
Okay.
He's pretty tech savvy, so I think we're gonna be okay.
All right.
He's coming down Wednesday, so we're gonna check out the room and see if they have everything set up ahead of time, so.
Yeah.
Hoping everything will go really well. So on Thursday, you will have a little pre-quiz for your new topic.
Okay.
But you won't have your quiz on today's topic until Friday.
Okay.
Oh,
Yeah.
that's the post quiz.
That's because you have other classes on Thursday and we don't want you studying for extra things, just your newest topic
Okay.
I see.
for the day, and then you have an extra day to study when you don't have any other classes.
Yeah.
Mm.
We're trying
Okay.
to put the timing so it doesn't disrupt your other studies.
Okay. Awesome.
Okay.
As much as possible. This
Yeah.
is an extra load of study for you, so we're
Yeah.
trying to do it in a way that's not quite as disruptive to,
Okay.
to your overall weekly responsibilities.
Yeah. So does every topic have a pre and a post quiz?
Yep,
Okay. Okay.
yep.
Cool.
And we're going to try to keep the pre-quizzes shorter
Mm-hmm.
because we don't want to spend too much time. Did we cover all of? No, I don't think we did. We have to go back to our quiz. Did we cover all of the topics in our quiz in our lecture? Did we see all the pictures? We saw this one.
Mm-hmm.
So
Yes.
this one was the aspirin burn,
Aspirin burn.
Aspirin burn.
and this one was the
Context.
contact stomatitis,
Morsicaceae.
morsicaceobacarum.
Yeah, but okay.
You missed that one, but
Yeah.
you'll never miss it again because
Yeah.
now you know how to tell them apart.
Yes.
Yeah.
This one,
Ooh, okay, female complains tender gum past 2 months. She chews a lot of gum. Okay,
favorite flavor is cinnamon.
That's the thing. So I'm thinking contact stomatitis.
And you're right.
Oh, okay.
That's what I thought.
Yeah.
Like,
So you don't see a lot of redness, but you do see how it's a little bit grainy.
Yeah.
And she has a lot of physiologic pigmentation, so it's hard to see color changes because of that. But yeah, this was contact stomatitis. Yeah, she loved cinnamon. And this one, we talked about, this
Oh,
is
yeah,
our traumatic ulcer
Mhm.
from the rubber dam clamp. This one,
Recurrent aphthous minor.
minor. Recurrent aphthous minor.
Hematoma.
Hematoma,
Angioedema.
angioedema,
And laceration.
traumatic
Okay.
laceration,
Mhm.
and
This
Oh,
one is the penicillin allergies.
That's
so the diagnostic term is,
stomatitis medicamentosa.
Yeah.
yes, stomatitis medicamentosa.
Yeah.
Good job.
All right.
Good job, one and all. And
Cool.
we finished
Yep.
a little before 4.
Awesome.
Thank you.
All right.
So I like the way that you that it's a small group and we can talk
Yeah.
about things and
Yeah.
you can ask all the questions you want.
Yeah.
And this is a good way to learn.
Yeah, no. I'm hoping to get pathology.
No, but you do want to be a great hygienist.
Great.
Yeah.
Yes.
At least,
And do
yeah.
well on your boards and know what to do with